welcome to the Extra Mile. I'm Linda Boudreau. Today we're talking about the Breast Health Symposium, which will be held here in Lafayette. And we have with us Reatha Williams. She is a breast surgeon and is the keynote speaker for this year's Breast Health Symposium, and also Maitland, Deland, who is a radiation oncologist here in Lafayette. So welcome both of you.
Thank you.
It is so good to have you here. We're very excited. I'm personally very excited about the Breast Health Symposium. I know this is the 18th year, and it's an event I think that has probably had some impact on saving lives. Would you all agree with that?
Absolutely.
Absolutely, yes. I think that, women that come to this, they get a lot of good information about breast health and some of the newer information, and that's got to be helping to save lives, increasing the awareness of breast cancer.
And I think the nice thing about this show is that, we have a very knowledgeable keynote speaker, but then knows all about genetics and risk for breast cancer, and is very down to earth. So I think anybody in the audience is going to feel like they can talk to Dr. Williams and ask questions. And then there are a lot of different vendors, like breast prosthesis vendors and all kinds of breast cancer literature. Susan Komen, everybody has a booth. So I think it's a wonderful forum where you get everything at the same time, and then you have all these women and there's this camaraderie, and so you don't feel like you can't ask something, because you can ask anything.
Because it's like this, it's a esprit de corps kind of an event where everybody's there kind of with a common interest. And you don't have to have breast cancer to care about this.
No.
I mean, we all have friends, sisters, mothers that have had this.
And we all want to know what our risk of breast cancer is.
That's true too. And so you are really, you know a lot about the risk because there's this whole genetic link that's coming out. So what is that all about?
Right. Well, this year we decided to make our topic, We Are Family, and it's the role of genetics in breast cancer. So I think it is a hot topic right now, and women are wanting to know, what are their risks, especially if they have a family history of breast cancer or ovarian cancer, because you know how things run in families. Your father had blue eyes, you're going to have blue eyes,
right.
Color of your hair, whatever, those genetic traits get passed down. And we don't always just get the good things. Sometimes we get some tendencies to have other diseases. Like heart disease will run in a family, or diabetes will run in a family. Well, sure enough, we have a lot of families here in Acadiana that breast cancer runs in their family. And having that genetic or that hereditary breast cancer, women need to know. And they need to know, what the risk is and what can be done about it.
So how do we even know if we should find out what our risk is? In other words, how do we know if we might be at risk?
Well, I think that, basically talk to your doctor about it, your primary care or your GYN, and ask them what they think your risk is, because we do risk assessments on women, which takes into account their personal history, their gynecological history, their family history, but especially in those women that have a family history, either a mother, a grandmother, a sister, a daughter, an aunt, with breast or ovarian cancer. Those are the ones that particularly need to be talking to their doctors about it and saying, what is my risk, and is there anything that I can do to decrease that risk? Do I need to be screened differently? How do I need to be followed compared to someone that doesn't have that risk?
Okay, so does it matter if the breast cancer is on my mother's side or my father's side? In other words, what if my dad's mom had breast cancer? Does that make my risk less?
No. It doesn't. You're at the same risk as if it was on the mother's side. And a lot of people don't realize that, men can get breast cancer too, and they can carry a gene and pass it on to their children. So it doesn't just have to come from the mother or the mother's side. It can come from the father or the father's side as well. And then you have families that have it on both sides, and then, they're going to be even at more risk. So taking that really, really important family history and getting all that, down and knowing for sure what your risk is, it's going to empower these women to be able to be more proactive in their health, especially the breast health.
Okay, so if they do find that they're at higher risk, then there are things they can do, or they just have to live with that fear?
There
are many things that can be done, especially if you have the BRCA1 or 2 gene. that means you're at 80% risk for having breast cancer at some point, and maybe 20 to 40% risk of having ovarian cancer.
Even if you live a very good lifestyle and do everything right.
Yeah, I mean, there's sort of environmental factors and personal health factors, but then there's the breast cancer gene, and
which is not all that common, is it?
no, it's probably, I would say 10% of breast cancers are hereditary.
Okay.
And probably 80% of those are the BRCA1 and 2 genes, and we're not sure about the other ones.
Okay.
But if you do have BRCA1 or 2, I think it's a very serious decision that patient needs to make, because typically BRCA1 patients are younger, they're premenopausal, they're usually estrogen progesterone receptor negative.
Meaning what? What does that mean?
If they get a tumor, it doesn't respond to estrogen or progesterone.
Okay.
But somehow, if you give tamoxifen, it decreases their risk. So we don't. Some things are not explained very well. So
The body is
right.
a miracle.
And she can tell you that you either have to do very, very good screening if you have the gene, which is alternating MRIs and mammograms, and even doing the pelvic and vaginal ultrasounds for the ovarian cancer, and getting the marker, the CA-125 for ovarian cancer, which is a little bit, it's not 100%, but I mean, what is? I mean,
Yeah.
It's sort of what we have. And so then those women need to make the decision, are they going to do this very, this very substantive screening, or are they going to decrease their risk by, having their breasts removed, or having an oophorectomy, or taking medications? And Reatha can address that a little bit more, because I'm sure she has the first conversation with that person when they have the gene.
And I just kind of wanted to let people know that we all have these genes, these BRCA1 and BRCA2 genes. But what these women have that have the hereditary tendency for breast cancer, they have a piece missing on that gene that is protective, and that protects against breast cancer. And if that piece is missing, then that makes them more susceptible to breast and ovarian cancer. And so somewhere along the way, that one little chemical or one little piece of DNA gets changed, and that change is what we're looking for. And we do have a blood test for that now, and it's a simple blood test. So if someone has a really strong family history of breast or ovarian cancer, then what we do is we do the risk assessment. If they fall into that category, they get the testing done. It is a big decision whether to do it or not, and some women want to know and some don't. But I think that it does give them the power to make some decisions in their life about their own health. And there are many things that can be done that can prevent it, like Dr. Deland, Maitland was saying. There's medications that can be given. There are different lifestyle changes that can be made that will decrease the risk. But also the preventative surgeries that we're talking about, and we're talking about removing the breast tissue, removing the ovaries.
So if you just remove the tissue, then the problem's gone?
Oh, it decreases the risk. If you do mastectomies on someone that's has an 85% chance of getting a breast cancer in their lifetime, it decreases that at least 90% or more. They go back into the normal range, and okay. We're all at a little bit of a risk.
Right. Because we're living
and the older we get, the more risk.
It does happen.
But it really does decrease that risk. And doing an oophorectomy on those patients, it decreases their risk of having ovarian cancer by about 96%, and it decreases their risk of having breast cancer by about 45%. So it decreases the risk of breast and ovarian cancer by removing the ovaries, because a lot of the breast tumors are responsive to estrogen. And you take away that source of estrogen, then it decreases that woman's chance. So there are a lot of preventative things that we talk to them about. We actually have a high-risk program, and we talk to them about risk reduction strategies. And, a lot of women are involved. We have a lot of high-risk women here in Acadiana. Oh, yes, a lot that fall. Anybody that's over a 20% risk is considered high risk by American Cancer Society American Society of Breast Surgeons, they've kind of put us in a criteria, and we do a risk assessment, and most of us fall below 10%. And around 7%.
Right.
And that's a lifetime risk of getting breast cancer.
Okay.
But if you fall in the 20% or above, then you're high risk, and you're treated differently as far as screening. We don't not only screen with clinical breast exams and with mammograms yearly, but we also screen with MRI in those breast MRI in those high risk women. I'm a big fan of MRI in high-risk women because it can pick up maybe 3 out of 100 more breast cancers than mammogram on those women. And
why not just do MRIs on everybody instead of mammograms?
it's a good question. It's an expensive
It's
test,
expensive.
number one. And number two, they haven't really proven yet that in the lower-risk women that it's gonna be beneficial. Right now, the studies have only been with the high-risk women,
Okay.
and they haven't really studied. They're doing a study right now on that moderate risk group, the 10 to 20%. Will it benefit? How many more breast cancers would we find if we were screening with MRI? And so that might change in the future. I have a feeling it might.
Okay.
When that result comes out, and we may be starting to screen more with
We
MRI.
may find the cost goes down over time too.
It
should,
The equipment's
yes.
paid for, and
Right, and I think ultimately, when people come out with these, like we were talking about the breast cancer task force said, you only need to have mammograms every 2 years. Well, everybody's different. Obviously, each person has 30,000 genes, so you can't have, one thing doesn't work for somebody else.
Right.
So I think eventually we're going to be getting to the point where we have custom screening, okay? But for right now, I think for the high-risk people, we know we need to do MRIs and mammograms. And for probably, I bet it's going to happen with those intermediate-risk people also, that the MRIs and the mammograms are going to be needed. And maybe in the low-risk people, you'll just need to do a mammogram yearly. I would doubt that it's going to get to be 2 years, because your risk of breast cancer increases with your lifetime.
And I
So
think
the older you are, the higher your risk of getting breast cancer. And so if you're in really good shape, and like the lady I saw today is mowing her lawn and she's 75, why wouldn't you do a mammogram
Right.
on her?
yeah,
But
yeah, why wouldn't you?
on the other hand, if somebody is, critically ill with, horrible heart disease and and just in bad shape, of course you wouldn't do that. You wouldn't put somebody through something like that when that they're probably going to die of cardiac reasons. So you kind of have to use a little bit of logic and not do these black and white statements, like it's either this or this, because it really isn't.
And what you're referring to, just to kind of give it some lead up, is who made the decision that we should only have mammograms every 2 years? That came out a few years ago, didn't it? It was like a
Yes.
recommendation.
Right. It was more of a retrospective look at things to say, are these women really benefiting from having a mammogram every year? And a lot of people are disagreeing with that statement.
Because they said, no, you don't need it every year.
Right. And
Not true.
they said not to even really start until 50. And it's like, I have so many 35-year-olds and 45-year-olds in my practice with breast cancer, and without mammogram, many of these would not have been
And
found.
it's more aggressive when it's a younger patient. It's
Yeah.
typically more aggressive. And so I think that's the wrong thing. That's a wrong message to send. I think that's more, I guess whoever made that recommendation, you should ask them, well, what have you recommended for your wife?
Or your daughter.
Or your
Your
daughter. Yeah,
Yeah.
so, I mean, sometimes things become impersonal. And it's a shame because when I walk in a room and when Reatha walks in a room, that person is part of our family. And we're going to take care of them like that. So I just think some people get too removed from the person.
Yeah.
And so that's one reason why I really like this conference, because everyone's together. I mean, we're really all sisters.
We really are.
And so
really
I
are.
that's what I like about the symposium.
Just I want to follow up on this. So we know that there were some recommendations that maybe aren't ideal. So what are the recommendations? Annual mammograms, and what else?
Yes.
And start when and go till when? I mean, what
So
age should we
typically
start?
it's starting age 40.
Okay.
Okay. And it's yearly mammograms. And actually, if you have dense breasts, you should also have an ultrasound or an
Okay.
MRI. And then if you have a history of breast cancer, the basic rule of thumb, and this could have changed, but it's like 10 years earlier than the earliest member diagnosed.
Okay.
Or if you've had, like if you had Hodgkin's disease and had radiation, then they're recommending mammograms no earlier than age 25. But usually your risk comes 8 to 10 years after your treatment. So, and there are a little bit of variances in those things, but it's that's pretty much where the standard is right now. So it's not, cast in stone for everyone. You have to look at all the individual characteristics of the patient.
And that's why an honest rapport with your primary care physician and then other doctors is so critical, right? I mean, you just can't go in there and make stuff up and tell your doctor whatever and think you're going to get great care.
No, and then Reatha was talking earlier about somebody palpating a lesion.
Yeah, I had a patient just this past week that she came in and she said, I felt something in my breast, and she said, it's not really a lump, but it's a burning sensation. And she said, that hasn't been there before. And she went to her primary care and told them, and of course they ordered a mammogram, and the mammogram was completely normal. And the patient said, well, I'm still feeling it. So she called her doctor again, and he had the good sense to listen to his patient, and he actually ordered an MRI on this patient to better evaluate it. Came back and found a breast cancer there. She had actually found it herself. So like Maitland was saying earlier, she said, not doing a self-breast exam, I think it's wrong. I think you should check your breast. You should get to know your breast and know, is there a change, and be proactive and be persistent. Just because that mammogram is normal, if you're feeling something new and different, then you call that doctor back and you tell them, I'm feeling something here, and I know it didn't show on my mammogram, but I feel like there's something here, and it may need to be evaluated more. And so that self-breast exam and knowing your own breast, I think, is still important.
It's very important.
And I guess the other thing I want to drive home is the fact that the survival rate of early detection is very high, isn't it?
Oh, yes.
Extremely high.
And so don't let fear keep you from...
Exactly. Fear, or some people say, well, breast cancer doesn't hurt. Well, you can't necessarily make that judgment, because they think, well, maybe I have an infection. Well, if you're having pain in your breast, you need to go see your doctor.
Period.
Because, I've heard people say, well, cancer doesn't cause pain. Well, yes, it does. You can't make that determination. So if you feel something abnormal, you should go in. Or if your breast hurts, you should go in.
Okay.
And that's another thing, sometimes breast cancers, you can feel pain, you will see some changes, you'll feel a lump, you'll see some redness, but sometimes women, they don't feel the lump and they don't know they've got it. And so that's why that screening mammogram every year after 40 is so important, because, I had a lady tell me the other day, she said, well, I get my mammogram done every year. And now you're telling me I have a breast cancer. She said, I didn't feel anything. My doctor didn't feel anything. And I said, mammogram doesn't prevent you from getting breast cancer, but it detects it early. We find it early, so that's when it's the most treatable and most curable. And these women that put off having their mammograms for 5 years, boy, that's when we find the cancers that are more advanced, and sometimes it's to the point where it's very difficult to get control of. But finding these very, very small, tiny ones that you can only see on mammogram, that's where we want to find them. We don't want to find them at all, but if we find them, we want those really, really small, early ones. Because stage 1 breast cancer, you've got a 95% cure rate. That's really, really
That's
good.
That's a really good percentage. It's definitely
happens,
the odds that we all want to play. So,
exactly.
And I believe there's a lot of fear out there still. I think people, might feel something or suspect something and just put their head in the sand and not want to know.
They do. I have had a lot of people come in and I say, did you feel this lump? And, you don't want to make them feel bad, but it's like, did you not tell anybody? And a lot of them, it's, well, I was busy and I thought it was going to go away and I didn't really think it was important.
Or I was taking care of my parents or something. I was being a caregiver and didn't do it.
Mm-hmm. And they neglected themselves, and they neglected their health. We all, especially women, we get caught up in our families and in our jobs and doing things, and we're really busy, and we kind of sometimes, like I say, put ourselves on the back burner and don't take care of our health. And I think it's very important for women to realize that, their breast health is important, and there are a lot of things that can be done to prevent breast cancer, not just to detect it. So we're going to talk a lot about that at the symposium as well.
Excellent. Now, you two both have been big supporters of the symposium for a long time too. Yes. I mean, like, you sponsor. You're one of our headline sponsors. So, why do you make that kind of an investment in the symposium?
Well, I mean, I think it's one of the biggest forums for all women to attend because it is free, and you can get so much information at one time, and we always have a great speaker. Here we go. Ta-da. And there's so many different, like I said, booths that are going to tell you about prosthesis and tell you about different support bras that can be used and different reconstructive techniques, and there's just so much information. And then sort of being in there and being surrounded by these other women, and we're all in it together. It's very supportive, and it's nice because it's sort of a comfort zone that I mean, I'm not saying that men aren't great or anything, but it's sort of mostly women, and I just think you can be a little bit more outgoing and more talk about things you may not talk about when you're surrounded by other women.
And I think another thing, what impressed me about the symposium is how it really honors the survivors, and they're kind of the highlight of the whole. They are. They're the centerpiece of the whole thing. And these women are so courageous, and they've been through so much, and they are there, and they come out in force, and they're fun. They put on a style show, and it's great. It's such.
Are we still doing the calendar? Do you do the calendar?
Yes, we're doing the calendar, and I mean, and like she said, the style show. I mean, when I've asked somebody, "Do you want to be a model?" they'll think about it for a minute, and because everybody isn't like that. And then I said, it would really help people because you are really well. You're smiling, you're happy, you're energetic. Get out there and get to wear those good clothes. Those nice clothes, and it's just...
And just have fun with it.
Have fun, exactly.
I think for women, too, with the style show, one of the things I've always thought was so important about it is to feel pretty again. After if you've had a mastectomy, or if you've lost your hair, or if you haven't had the energy to put on makeup and your skin isn't like it used to be and everything has changed, and to have an opportunity to get back into that kind of groove of being who you are.
Right.
I think it's really just exciting.
Oh yeah, they get a complete makeover.
They do. Yeah, it's great.
They go and they have their hair done, their makeup, they get their clothes, there's people from around town that different people that sponsor, and they just have a great day, and then it ends up, this is kind of the finale.
They come in a limo. It's really nice, and and what I try to emphasize to some of my patients is, what isn't pretty? Cancer isn't pretty. So as long as you're cancer free, that's what counts. That's what's beautiful. It really is.
And the spirit that you have within you is just, it just really does glow.
Oh, it just shines in these women. So that it's a great event. And if you haven't been, you need to come. If you have been, we always want to go back because it's just so great.
And again, the particulars, because we're running a little short on time, but it's going to be when, we have a couple of minutes left, but it's going to be when, where, it's free. When is it?
It's October the 12th. And it's the doors open at 5. It runs from 6 to 8 is the actual symposium, but the doors open early so women can come and go through all the booths. They have drawings and giveaways and things like that.
Okay.
Everything's free.
They have food there too,
They got
don't they?
food, yes.
Yeah, they do.
Yes,
Yeah.
and it's at the Cajun Dome Convention Center.
Right,
So it's
right.
lots of parking and very convenient.
Now, is there anything people don't have to pre-register? They can just show up if they
Can
want
just show
to.
Show
up.
up and yeah.
Men are welcome.
Yes.
You know. And I think it's a great sister event too. You know, like if you want to get a group of your girlfriends together and just go and
Yeah, that's a
and
great idea.
Check it out, kind of thing. I think and then talk about it later. I think it's a really good thing. I just want to thank both of you for what you're doing for our community, really, because not just your skills and your talents, but the heart and the passion with which you do your work, I think also helps in healing. I really do believe that, because working with doctors who understand and care and give so much means so much to all of us. So thank you both for your professional help as well as your community spirit.
Oh, thank you so much for having us.
Thank you. And thank you for watching The Extra Mile.